All right, welcome back to the show, everybody. On today's episode, we have a very special guest, Chris Cummins. Chris, how you doing, sir?
I'm doing great, man. Good breakfast this morning. Got my water with me. I'm all set. How you doing?
Yeah, same. Actually, I had a great breakfast, good coffee, and it's Friday, and I'm fired up to learn more about you and what you do. So, with that being said, could you tell us a little bit about yourself and how you help people?
Sure. Yeah, absolutely. So I'm the chief clinical officer here at Laguna Treatment Center. We're a 90-bed detox and residential facility in Orange County, the second largest chemical dependency recovery hospital. My role is I'm the clinical director and the COO, so I oversee all the therapists, all the clinical programming, but I also oversee the strategic planning across all the different departments and how the operations go. That's my role here.
Nice. Thank you for sharing that, Chris. Who do you see in your agency?
So, substance use is primary for the diagnosis, and mental health is secondary. So, we have co occurring disorders that we treat for all the patients, and we have a high level of acuity that we can accommodate. So, if we have patients that come in with a typical alcohol diagnosis and no mental health, we can treat that. But also, we see patients really high level meth use disorder with co occurring schizophrenia. Really, as long as they can reality test, they know who they are, where they are, what they're doing, and they're not trying to kill someone or kill themselves, we can treat them. If they rise to that level of acuity, then we're typically referring out for a hospitalization.
Got it. Do you see teenagers, women, men, adults? What does that look
18 and up, and
like?
both men and women.
Got it. Got it. Yeah, that's really cool. Chris, how do you know if a client is a good fit for you and if you are a good fit for the client?
So we do typically an ASAM assessment when they come through. And ASAM is American Society of Addiction Medicine. It's the gold standard for placement for substance use disorders. So when we do that evaluation, we can determine, is this patient meant to be an outpatient where they can just see a counselor on a weekly basis? Are they more of a fit for IOP where they're just doing group therapy every now and then? Or do they need to be in something more intensive where they need to be removed from their home environment, live with us for a bit, be able to address all their concerns within the different elements of the ASAM, and then return home after that? So the ASAM is really our guide. What's the level of severity in each of these six different categories of the ASAM, and do they belong here or not? So that's how we determine if they're a good fit.
Yeah, and I one of my practicum sites was at the a recovery center, and I know all about ASAM. It's very thorough, a lot of categories, and yeah, it could really capture a lot of information from the client. All right, so let's say somebody does the ASAM and they're a good fit, and the ASAM is completed, the assessment is completed. What is kind of like the beginning phases of treatment look like?
The beginning, when they come through the door, typically they're starting off with a detox protocol. So when they come in, we do the initial assessment with the nurse. We do a H&P or a history and physical with the doctor, and then the therapist also does a biopsychosocial assessment. So after these assessments are done, they get put into the ASAM for placement, determine the right level of care, and then they're typically starting off in the detox level of care, which is the highest level of care before you get to the hospital. There's a high level of medical needs. We're managing the withdrawal symptoms, managing the mental health components. And the way that we decide how we're going to treat clinically for the patient is based off of these answers from the biopsychosocial assessment, the nursing assessment, and the H&P. So let's say there's all kinds of problems listed on the BPS that we need to be able to address. The BPS is the biopsychosocial. We move those into the treatment plan to be able to say these are the different things that we've identified through the different assessments, and this is how we're going to treat it. And then we review it with the patient within the first week. We talk with the patient, we say, hey, based on all your assessments, these are the different areas that we're going to treat, these are the priorities. And then we collaborate with the patient to be able to say, how are we going to work on this together? And
Yeah.
this is what we're going to start off with because these are the most prevalent or the most important to address in the beginning. And you might address really important things later on, like, for example, trauma. So they'll come through the door with a high level of trauma. Very first off the gate, in your first meeting with your therapist, you're probably not going to address your deepest, darkest traumas. Likely in the very beginning, you're going to say, hey, how are you doing? How are you feeling? Because I'm super sick right now. I'm going through withdrawal symptoms. I need that managed first and foremost. I'm just being a human with you. And then as you're moving through that, you get to those deeper core clinical elements, and maybe on the 30-day mark or further, you're diving into that trauma to be able to address it. So that's how we treat them from the beginning.
Gotcha. You mentioned a therapist. So is a therapist assigned to the client? How does that work?
The therapist is assigned from the moment they get through the door. So they have a therapist and they have a case manager. Typically, the therapist is assigned based on the best fit for the patient, but sometimes we'll mix it up. It could be a female with a male patient. It could be someone that was struggling with a certain population. It's all the assignments are very intentional. And then as they move through the program, really the rapport develops. So yes, from the very beginning, they're assigned therapist.
Got it. Chris, so out there in the mental health field, there's all kinds of specialties. We got brain spotting, CBT, DBT, on and on, all these great, wonderful specialties. What does your staff primarily focus on, if there is a focus that they use?
So it's a super wide variety of things that we address for addiction. So addiction is not just a one-way street. It's not a one-size-fits-all. So I can't say, hey, we're going to prescribe you CBT therapy and then everything's fixed. It's really a vast amount of interventions that we use for each patient. I'll give an example. So for one of our group curriculums, we use Seeking Safety. Seeking Safety is the gold standard for treating mental health, substance use disorders, and veterans with complex PTSD in a group setting. So we use that as one group curriculum. We also have equine therapy. We take our patients off site and we do equine therapy with horses. We do yoga on site, breath works to learn how to use the breath. There's also, so we have yoga therapy, breath works. We also take them off site to be able to do like beach outings and throw some fun into recovery. So there's all kinds of different interventions on a larger level that are fun and to mix it up. And then on the micro level for the therapist, motivational interviewing is huge. So motivational interviewing, initially it was meant to not be a therapeutic intervention. It was really just a means of talking to another person, to another human being, to get them through different stages of change. So if you're familiar with the stages of change, a lot of patients come in this stage called pre-contemplation. And pre-contemplation basically means I don't have a problem. I'm not supposed to be here. My wife made me come here. I'm not supposed to be here. The courts made me come here. I'm not supposed to be here. I just really need a place to stay for a little bit until I get back on my feet. So that's pre-contemplation. There's this belief that there's no issue at all. And then there's a slow move into the next step, which is contemplation. And maybe I have a problem, and maybe there's something that needs to be addressed. So motivational interviewing is a method to be able to move them through those different stages of change, to be able to say, hey, I don't have a problem, maybe I have a problem, and then eventually I do have a problem and I need to do something about it. And that's when things start to change. The treatment plan gets addressed, they start connecting with the community, and the healing takes place. So motivational interviewing is a great approach, but then of course we prescribe those DBTs, the CBT, based on different things that the patient needs to be able to address while they're here. I'm a personal fan of solution-focused brief therapy. There's a lot of evidence that that's a great intervention for substance use disorders. And what I like about it is the fact that it's strength-based, it's future-focused, it's hope-building. So solution-focused for me, that's my vote.
Awesome. Yeah. So it sounds like there's a lot of tools in y'all's toolbox to be able to help a wide range of clients. Does that sound about right?
Mm-hmm.
Yeah. Awesome. Yeah.
Huge everything in the kitchen sink out.
That's awesome. Chris, there's a lot of styles out there. There's some clinicians that are really direct. They kind of tell the client what to do. And there's other clinicians that are really laid back. Some use humor, some don't, some keep it very, very professional. Some do a little bit more of that personal disclosure. How would you describe the style of your clinicians when they work with clients?
All the words that you said. So it's across the board. We have the very direct approach, where when a patient wants to talk to a therapist, there's the no BS, cut out all the things that might be fluff, and they just tell you directly to the point. Very good at intervening in crisis situations, address it like that. And then there's some that are a little bit more fluffy, and they may sit back and say, I wonder about this. I think this may be the issue. What are your thoughts on that? And they're a little more, give you some cushion on it. And then there's some that are right in between. They can go back and forth. They can vacillate, which is my preference. I like the chameleons. I think that's really great when you can have the direct approach, you can have the fluffy, you can meet everyone's needs. And the reason why I say it's a preference is because there's skills in both sides. There's skills to be able to be assertive and be directive. There's skills and be able to have some flexibility in your approach. So all of the above is needed, and sometimes they fall into a category, but I encourage the clinicians to flex the muscle for each side because clients need different things.
Yeah, and I appreciate you sharing that, Chris, because there really is some nuance with what the client may require. And especially when they're kind of detoxing potentially, or just kind of going through that transition between, substance use and then like weaning themselves off, and every day could be different, so I really appreciate that your team takes a really nuanced approach based on what the client needs. I like to talk about the program. So what is that? Do you guys do? I mean, you mentioned doing equine therapy and kind of doing some outings, but if they're not outside, if they're in, the building, what do they do? Are they doing classes? Is it like individual work? What does kind of like the schedule look like?
Yeah, so in the beginning of the day, start off with breakfast and medications. So they're getting some food in their stomach, they're getting the medications that they need for the morning. They go off to groups. So we have 6 hours of groups per day. So it starts at 8:30, we end at 11:30, and then there's a lunch period. After that, we do 1 to 4. Those are groups again. And then we do dinner in the evening and typically sober fun activities in the nighttime. So it could be like karaoke, it could be a foosball competition, it could be kind of whatever comes up, a lot of sober fun. But what I really want to focus on for a second is the group therapy component. So I just said a second ago, they have 6 hours of group therapy while they're here. So group therapy is the evidence-based form of treatment for addiction. That's why they have 6 hours a day of it. It's a very large, heavy-hitting prescription. So when you think of someone has chemotherapy because they have cancer, the reason why they were prescribed chemotherapy, the reason why this is in their treatment plan is because that's the evidence-based form of treatment for cancer. So years over years, they've done studies and they found that this is the best way to treat cancer. They did a similar study for addiction, and they say, what is the best way to treat addiction? And what they found was that group therapy was the most effective approach to treat addiction. So that's why it's prescribed at such a large amount throughout the day at 6 hours a day. And that's why in the step down through the continuum, so when they leave here, they have more group therapy, typically 5-6 hours of group therapy a day. They're just not living on site. And then they reduce to about weekdays, and then they're just doing that on the weekdays. After they leave from that, they'll do 3 hours a day for 3 days a week. They call that intensive outpatient. And then it slowly gets down to 1 day per week, which they call outpatient. So there's a titration from the time that they're here and they're living and have a large amount of group therapy, and then they titrate the group therapy. So it's kind of like a medication, you prescribe a very large amount. It's reduced over time depending on the symptomology.
Yeah, that's really cool, Chris. I like to ask about progress. What does progress look like for somebody that partners with your organization?
Yeah, in the beginning, it's interesting. It's a physical as well as an emotional and a mental. So in the beginning, they come in, they feel downtrodden, a lack of hope. They might be unkempt. They might feel like I have nowhere to go from here. And that's the appearance and the snapshot of the beginning. By the end, all of those things are typically addressed through the treatment plan. And you see it physically on their face, you see it in their body, you see it in the way they carry themselves, you see it in their confidence level, and you see in the way that they're relating to other people. So the relationships too. So success for us looks like they're discharging successfully, completed their treatment plan. They have a next step where they're connecting with an aftercare site like a PHP or an IOP. So they're going down the continuum for that added support and their reduced risk of relapse. And then also we do a customer service survey. So we ask them throughout their stay here and by the time they leave, what was your experience? And they give us honest feedback. It's anonymous, and they submit this feedback and they say, I had a great time with my therapist. This is what they addressed. I'm so grateful that I had them around. Or this is what I had for case management. I had some complex needs. I had legal. I had HR issues at work. I had to figure out my time off, and all that was addressed through my case manager. I'm so grateful, and I had ease of mind. And when we hear those things, it's a success. say, we've done great by this patient. And then to the opposite effect, of course, we can't do everything perfectly. So sometimes when we hear that feedback, when we hear, hey, maybe there was too much time spent on breaks and groups, happened way too often, and we hear that, and there's 3 different reviews that say it, we need to go back to the drawing board and address our needs. So success looks like we've treated the patient well, addressed their treatment plan, and they're moving on and they're sober. And then to the opposite of that, if we hear these feedbacks, it's not necessarily a failure, but it's things that we can learn from to improve our program.
Yeah, yeah, absolutely. So it sounds like you're really intentional about actioning whatever feedback is provided, and also, what, like there is success that's being experienced, and I think that's really awesome. What is the feedback when clients successfully complete the program? Like, what do they say about just the overall experience of being at your agency?
It's so funny because it could be so many different things. What we hear is the groups are incredible. I really loved, and I'm a name drop here. They say, I really love Gilbert. He was an awesome facilitator. He just knew me. He knew my story. He came to check up on me. And when they mention individuals by name, that's so meaningful because it's like that rapport was built. They remembered the name. They specifically mentioned them. And that's the meaningful interaction. The same thing for yoga. We hear that every so often. Yoga was a huge help for me. Every time I went in there, I just got in that mindful mode. It took me out of whatever I was experiencing in treatment. And I have a passion for it now. I'm going to use that later on. Or they might say equine was fantastic. When I went to see the horses, I didn't even know that was possible as a trip. And they say that was the most impactful for me. So that's why, going back to one of your first questions, how do we treat addiction? It's throwing everything in the kitchen sink because not everything lands the same way. If we did a soul yoga program throughout all the treatment, that was our group therapy and that was our clinical intervention, it might land well for some people, but we're going to miss 95% of the population. So we have to address these different methodologies to be able to say what's the best fit and what's going to match best for this patient. So the answer is a lot of everything. There's always going to be something that fits particular for someone.
Yeah, sounds like the feedback has been pretty good overall.
Mm-hmm.
And shout out to Gilbert. I don't know if he or she is listening, but yeah, you're doing good work over there, Gilbert. Keep up the great work.
Yeah, Gilbert's a killer.
I'd like to shift gears a little bit and ask about your agency. What's on the horizon? Are you guys rolling out any additional programs, maybe opening up additional location? What does that look like?
Yeah, so just in our purview, virtual IOP is something that's high on our radar. I'm a huge fan of outpatient therapy and being able to own that at every site that I've worked at before. We've had an inpatient and an outpatient. And the reason why is, so we have trusted partners. We have a lot of people that we work with within the community and we refer out to them, and it's fantastic. Something that's evidence-based when you look at the data is when you have a break in treatment, the odds of success drop. So when you can continue within the same umbrella, the same treatment center, and have inpatient rolling into outpatient seamlessly, the outcomes are a lot better. So I would love to be able to own an outpatient or for Laguna, own an outpatient where we say, you're at Laguna and you're discharging to our PHP, our partial hospitalization program, or you're discharging to our IOP, or you're discharging to our virtual IOP if that meets the needs of your workplace. So virtual IOP is next on our horizon, but outpatient in general is a high need, and it would increase the quality of our outcomes for our patients too.
Yeah, that's awesome. And I've heard great things about the few agencies that have virtual IOPs. They say that it's a game changer just as far as like the logistical flexibility that it provides, right? Like people can just sign in from their living room. They don't have to drive anywhere, deal with traffic. So that's always a big plus. Yeah, that's awesome, Chris. Anything else? Are you guys maybe opening up another location, hiring more staff?
Yeah, those are the biggest things. So we have 8 facilities across the United States. We're the only one in California. So it's really based on facility, and I don't think AAC, American Addiction Centers, the umbrella company, I don't think that they're looking to expand. We really have a sweet spot right now. We've been a lot bigger. We've been smaller than we are now. So the fact that we've stuck around with 8 facilities for a while now is pretty incredible. So I think we've got about 3 years that we've had 8 facilities, and the focus is really improving the quality at all of the sites. And I love that. What you're doing, if it's going well, stick with that. But for us, Laguna specific, we'd love to expand into outpatient.
Yeah, that's awesome. Chris, if somebody wants to reach out and partner with you, how can they reach out?
Yeah, the best way to reach us is calling through to the line. It's 949-647-4285. 4618. And when you call through the line, that's the call center, and you'll be able to ask about the program. You'll be able to express interest in admitting here. Just everything that you need could be in that number.
Yeah, super cool, Chris. Thank you for sharing your information and sharing a little bit more about the work that you do. That's really awesome. Yeah, I really appreciate it. And thanks for coming on the show. Maybe we could do it again in the future. How does that sound?
Yeah, I love it. Yeah, let's keep the conversation going. I love that.
Yes, sir. Absolutely. All right, everybody. Thanks for checking in with us today. And until the next one, signing out. Bye.